Hello, everyone. This is Janice Hansen, and I'm one of the co-chairs for the Colorado Cancer Coalition Survivorship and Palliative Care Task Force. We're very happy to have you join us on this webinar covering a topic that is very important to us in Colorado, and we certainly appreciate Dr. Jonathan Treem sharing his expertise and information with us as we go forward. So I wanted to let you know a little bit about our task force before we begin. We are designed to help collaborate to improve the physical and mental health of cancer survivors, including those receiving palliative care in Colorado. And if you have an interest in participating in this coalition and this task force, please send an email to survivorship@coloradocancercoalition.org. In order to proceed, I want to let you know that we have quite a few folks on the call, so you are all being muted so that Dr. Treem can go ahead with his presentation, but you can use the chat box if there are specific questions or other concerns that you might have, or you're having any trouble viewing or hearing this audio. So without further ado, I'd like to introduce Dr. Jonathan Treem. He is a hospice and palliative care physician at the University of Colorado Health with Anschutz and the School of Medicine. He received his hospice and palliative care fellowship in 2017 from the University of Pennsylvania, and he has many other degrees with regard to his medical degree from Warren Alpert Medical School at Brown University, and did his residency at University of Pennsylvania and his undergraduate at Yale. So welcome, Dr. Treem. We really appreciate your presenting with us today, and feel free to let us know anything more about yourself that you think would be helpful. Thank you.
Okay, thank you so much. That was a fabulous introduction. I appreciate it. My name is Jonathan Treem, or John, whatever floats your boat on any given day is fine with me. I'm one of the palliative care doctors here at the University of Colorado, and I really appreciate all your time and attention today. This is an important topic. So we're going to talk about medical aid in dying. Okay. So I have no relevant disclosures, no substantial financial relationships, but from a personal disclosure standpoint, I drink too much coffee. Just felt like that was an important thing to share. The goal here from this webinar is to understand a little bit about what Proposition 106, or what we refer to here as medical aid in dying in Colorado, has laid out in terms of the law and the protocol for participation. One should understand a little bit of the history and the data and the ethics behind the intervention. You should be able to counsel patients who come to you about medical aid in dying when they ask a little bit more about, they want more information from you. You should know your responsibilities when it comes to deciding to participate and what you're actually accountable for. And then lastly, to think a little bit critically about some of the ethical considerations around the practice. Okay. So whenever I give this talk, it becomes really important really early on to establish some definitions. There's a lot of kind of variation when it comes to the lay press, and even within the professional realm, when it comes to the different nomenclature we use to describe this kind of practice. And so for the purposes of this talk, I want to lay out what we use here at the University of Colorado. So there are three things that sort of get used interchangeably, but they are not really interchangeable. The first is this word euthanasia, which we define here as a person who takes an action to end another's life for the purpose of alleviating suffering. Something like mercy killing, but the idea is that the person takes an action that results in the death of another person. Medical aid in dying, which this is going to focus on, is when a terminally ill patient voluntarily takes a prescribed lethal dose of medication in order to end their own suffering, which we actually think is different than this thing called physician-assisted suicide, although in sort of popular press they're used interchangeably. Physician-assisted suicide is a patient takes a prescribed lethal dose of medication to end their own suffering. The difference being terminally ill or not. And I'm just going to harp on this for a quick second because I think it's important. When we talk about medical aid in dying, we talk about patients who are dying, who have a reasonable chance of facing their own death within a 6-month sort of time period. And what they're choosing is some control over that process. That is different than somebody who decides that they no longer feel that life is worth living or they want to continue living and is going to take a prescribed dose of lethal medication. It may sound like a subtle play, but the idea is that this is not a choice between life and death. These are people who, for whatever purposes, are facing their own death regardless of what kind of medical interventions are offered. And they are choosing the manner in which that happens. And it's a subtle play, but it's an important one. So we call it medical aid in dying, not physician-assisted suicide. And we don't believe that this is essentially a form of suicide. Okay. So before we jump into sort of the nitty-gritty here, it makes sense to talk a little bit about the history. So this is a long topic. There are actually books written about this, but this is a very abridged sort of chronologic history of aid in dying in the United States. Things in the kind of modern concept of aid in dying, and there's a long history before this, really started in this country in around the 1980s, when this gentleman, Derek Humphrey's wife, became terminally ill and felt that she would like the option to end her life peacefully when the time came. And then there was sort of an advocacy effort that branched out of that to sort of give her that right, because essentially at the time, that's illegal. Started in 1980s. 1984, in the Netherlands, there's a legal case where a physician actually does that for a patient. So a physician writes a prescription that they know to end a person's life peacefully, and it goes to court in the Netherlands, and the court decides essentially to not prosecute or not convict that physician for that practice. So it becomes legal by legal convention in the Netherlands, but not necessarily by law. It's actually not until a good time later, I think almost 20 years, that actually there's a law passed in the Netherlands. But for about 20 years there, it's essentially a legal convention practice where the medical associations of the time essentially defined best practices. In this country, there have been a couple Supreme Court cases that influence our ability to do this. In 1990, the Supreme Court decided this case, Cruzan versus the director of the Missouri Department of Health, that basically said that a person can determine what kind of medical care they find acceptable, including medical care that could contribute to their death when they are dying, as long as they have a, quote, clear and convincing directive. Right? So if there is no clear and convincing directive, you can't necessarily substitute judgment. But if there is, then essentially those wishes as written out should be carried out by the physician or the family. This is how we get established. We sort of established advanced care planning in this country. About 4 years later, Oregon passes Measure 16, or what becomes known as the Death with Dignity Act, by direct ballot initiative. So it's passed by the population by vote. It gets tied up in legal battles for about 3 years. Then in around 1997, there's another Supreme Court case, Washington versus Glucksberg. And in that case, actually, Glucksberg, the defendant, Washington was the defendant, Glucksberg was the person who brought the case, basically argued that the right to die or the right to request a prescription like this is a right guaranteed by the U.S. Constitution. And Washington says essentially it wasn't. So it goes to the Supreme Court, and the ruling here is actually really important when it comes to how we actually proceed in this country. Because the ruling is that access to lethal medication in the context of dying is not a liberty that is protected by the Constitution. So it is not something that is legal federally, but it is also not something that is illegal federally. So it's not actually defined by sort of federal law whether or not this is or is not permissible legally. And the ruling basically says that it's not only is it not defined federally, it's actually really a states' rights issue. So states are free to prohibit or legalize MAID essentially by their own values and discretions. And this is sort of how we get this kind of current climate in the United States where different states have essentially different policies and different sort of legal activities around this practice. For what it's worth, this one of the kind of medical philosophical concepts that comes out of the Washington versus Glucksberg case is that hastened death is allowed as long as the goal is relief of suffering. And really that comes out of the idea that, for example, when somebody is dying actively and they're very dyspneic and you administer morphine and you know that maybe that morphine will relieve suffering and may, right, shorten that person's life by incremental amounts, but the point is that they are suffering in their last time, that it is not illegal to give them something like a morphine in order to sort of alleviate suffering. Anyway, there are additional Supreme Court cases after that. There are a couple challenges to the law, especially in Oregon, that end up upholding the right of a physician to prescribe a medication if it's allowable under state law. That was 2006 in Gonzalez versus Oregon. Since that time, different states have had different timelines for legalization. So in 2009, Washington state became the second state, then Vermont and California. Colorado's Proposition 106 passed by popular ballot, called the End of Life Options Act in Colorado in 2016. And then since then, District of Columbia, Hawaii, Maine, and New Jersey have all passed similar legislation. So just as kind of a reference point, it's worth noting that there have been a whole bunch of sort of the long history of legal polling around this issue. And since around 97 or 1990, so stable for about 30 years here, polling has been relatively positive in favor of this practice when it is administered lawfully by a physician. So this idea that popular polling seems to trend and seems to be relatively stable around the idea that this is a practice that should be legal. I think in Oregon, if I remember, I'm sorry, not Oregon, Colorado, if I remember the actual ballot itself, it passed by something like 66% of the vote favorably. It might have actually been a little bit more than that, but it cut across party lines, socioeconomic lines, sort of regional and racial sort of designations or demographic lines. It was definitely something that sort of, from a political perspective, was a very positive response. Okay. This is just a reiteration. So now, currently in the United States, Oregon, Washington, Montana, and Montana is actually like the Netherlands. So Montana, it's legal by legal convention, not by law. So there's no law that says it's legal. It's just that there was a case where they basically said, we will not prosecute physicians who practice this. Vermont, California, Colorado, District of Columbia, and like I said, Hawaii, New Jersey, and Maine have all passed legislation since. Okay. We'll get into this a little bit later on in this talk as well, but it's worth noting there's not a lot of data out there about why patients choose to participate. There's some, and most of that data actually comes out of decedents or survivors who retrospectively let teams know this is what my loved one thought about when they decided to take this medication. But most of that data suggests that it is not necessarily the need or the pressure to end life peacefully that drives these kinds of decisions, but moreover, that it is the fear of dying with significant debility, loss of independence, this idea that there will come a time in the progression of dying where you will be entirely functionally dependent and that you don't want to endure that time, and that the prescription for medical aid in dying is something of a safety net. And so this idea that if it gets very bad, if the dying process becomes overwhelming, I have a way that I can control where I can die in a manner that sort of honors me. And that is sort of, the suspicion here is that it's borne out in the data as well, that there's a difference between the number of people who actually receive a prescription for medical aid dying and the number of people who die from actually ingesting the prescription, that there's a gap, and that gap has actually remained somewhat constant over the 20 years of practice in Oregon. All this data comes out of Oregon that you're seeing in front of you. And so somewhere in the neighborhood of 20 to 40% of prescriptions don't actually get ingested. And the suggestion there is, again, it's more of a safety net than it is necessarily an intention, although I'll say that is intuited from the data more than it is actually borne out. Okay, so the first 2 years here in Colorado, 2017 and 2018, this is a little bit about the data that we've collected. So every year here, state of Colorado publishes non-identifiable data about some sort of basic demographic understanding of how this is proceeding in the United States. So 2017, there were 72 prescriptions. 2018, 125, so it's almost doubled. Interestingly enough, the dispensation, so the people who have actually gotten prescriptions written for them versus the number of people who actually filled the prescription has gone down somewhat. Again, there's this concept of a fall off at every step, that it's not necessarily that people intend specifically to take the medication once it's prescribed, but that they're interested in the process as sort of a security or safety. Far and away, this is sort of true across the board in the United States from the people who collect data. Cancers are the diagnosis that sort of triggers this activation or this system for most people. Colorado specifically actually has a slightly higher proportion of people with neurologic conditions than data from elsewhere. And then pulmonary and cardiac are the other two most. Medications we're going to talk about, actually. Most of the original data comes out of Oregon, where they used a single agent barbiturate, secobarbital. That is actually, again, we'll talk about it a little bit later, that's actually no longer really available. The next most common is this thing, DDMP2. Again, we'll talk about it, but that is rising in popularity and essentially is sort of standard of care here in Colorado now. This is important, and we'll talk about this too, that the patients, and this is true in Colorado, and it is true in Oregon, and it's true in Washington, it's true most of the places that I've seen that actually collect data, that the people who are participating in medical aid and dying by far and away come from relatively stable households, have high degrees of education relative to the normal population, and have a higher socioeconomic status relative to the normal population, and are overwhelmingly Caucasian. We'll talk about this, but it seems to be that the population that uses this is not necessarily a population with few means. They're generally speaking a population with higher means and higher education. And then Denver in the Front Range for, I think, nearly 85% of prescriptions in the state of Colorado have come from that region. Okay, so the actual process here. We'll talk about this in a little bit of detail, but this is a rough overview. The patient has to present to the primary prescriber and request a medication through medical aid in dying. They must then, there are a whole bunch of criteria that have to be fulfilled here, and we'll talk about this. Then they must wait 15 days before they represent to the same person for their second oral request. At that time, they submit a written request, which is a form letter. Basically says, I know what I'm doing and I know why I'm doing it. They must then see a consulting physician, right? So somebody who basically agrees that they meet criteria for participation. And if either the attending physician or the consulting physician believes that the person's capacity to make a decision is impaired, there is a mandated referral to a licensed mental health professional who is defined as either a psychiatrist or psychologist for determination of capacity. That determination is only necessary, so that referral is only necessary if either the attending physician or the consulting physician feels that there may be some component of interference in the patient's capacity to make this decision. So it is not mandatory, right? If both on the consulting and the attending physician feel that there is no impairment in capacity, then no referral is necessary. Once that is done, the attending physician can write the medication order. At that point, the medication can be taken home. Okay, we'll talk about this in more detail. The attending physician then must complete some of the documentation requirements, including reporting to the Colorado Department of Public Health, and complete the death certificate. So the death certificate is signed by the primary physician for medical aid in dying, and we'll talk about that too. That's a very basic overview of the process. Okay, so here's the high yield about participation. So when it comes to patients, there are specific criteria set out within the law for who can actually request this medication under the law. From a patient criteria perspective, the patient must be over 18 years of old, so this is not available to minors, must be a resident of Colorado, and I will define residency for you. They must be quote unquote terminally ill or have a diagnosis that is likely to progress to their death with a prognosis of less than 6 months. I'm going to stop here for just a quick second because the prognosis piece is like prognosis in hospice, which is to say that the determination is that within a degree of medical certainty, you suspect that a patient's likely life expectancy is less than 6 months if the disease maintains its expected course. You don't have to be exact. There's no perfectly accurate prognostication tools, right? So this is if you believe as a physician or as a provider that this patient is likely to die within 6 months if the disease maintains its expected course, that is sufficient criteria for prognosis. The patient must have capacity, so they must be able to make this decision. They must be able to understand the risks, benefits, burdens, and alternatives. They must be able to make a value-based decision, and they must be able to communicate that decision. Definition of capacity. They must be able to self-administer the medication, so they have to take it. No one can give it to them. And there are a whole bunch of people who can't take the medication, say they can't swallow, or they're too weak, or they can't coordinate the movement. Right? That essentially disqualifies them. They must be acting voluntarily. So you must actually make sure that your patients are not being influenced by anyone who stands to substantially benefit from their death. And that actually requires under the law that you isolate the patient, right? So you take caregivers out of the room and you ask them specifically and in private and confidentially, is there anyone who is influencing your decision? And why might they be doing that? And this all must be documented. And then they must be making a quote unquote informed decision, which means you have to go through with them risk, benefit, burden, and alternative. And so there are lots and lots of ways to assure that a patient can be comfortable as they die, that their concerns around the end of life process are addressed, and that we can assure them that there are alternatives means of caring for them at the end of life. And you can describe hospice, palliative care, general end of life care as an alternative to medical aid in dying. So important that patients recognize that this is one tool in a toolbox. It is not the only way that they can assure themselves a peaceful death. From a provider perspective, right, no provider is obligated to participate. Right? That's very clearly laid out in the law. So if you are approached and you do not feel comfortable, you have no obligation. However, if a patient does want this and requests that their medical records be transitioned to another provider so that that provider can help them obtain a prescription for medical aid in dying, then you are obligated to transfer those records. You can't be a barrier to them getting that care from somebody else. You have to be an MD or a DO right now, so no NPs or PAs, according to the way the law is written. And then when it comes to capacity, so that decision about whether or not somebody has capacity, if there's a question, you must refer to a psychiatrist or a trained licensed psychologist here in Colorado. Okay, and we'll talk about this too. So there's some provisions laid out in institutions and their right to sort of determine what their employees do. The way the law is written, institutions may prohibit employees from writing a prescription for medical aid in dying for a patient if that prescription is intended to be taken on the hospital premises. That's actually what the law says. And there's a vagary there, which we'll get to in a second. Institutions may not compel an employee to participate, and they must notify all their providers and their patients of their policy regarding medical aid in dying in writing, and that if they don't do that, they can't enforce a policy that they don't communicate. Okay. All right, the prescription itself. So this has changed, and it's changed within the last 5 years or so. So the predominant data comes out of Oregon, where they were mostly using essentially a high concentration, high volume secobarbital formulation. Um, that is essentially no longer available. So the makers of secobarbital recognized that it was being used mostly for this prescription, essentially discontinued production. So I don't believe it's commercially available in the United States right now at all, which is why the red line is through it. The standard of care here in Colorado, and certainly here at the University of Colorado, is this formulation that we call DDMP2, or that's how it's sort of referred to in the medical literature, which is a combination medication of diazepam, digoxin, morphine, and propranolol at very high doses. So just as a reference, the dose of morphine in that combination is 15 grams. Right? So if you have any experience with sort of pain medication or opiate medication, a moderate dose of daily morphine may be something like 150 milligrams. So this is about 100 times that dose. Propranolol, diazepam, and digoxin. It's mixed together with about 120 milliliters of liquid. Essentially the time to the onset of coma from the ingestion is somewhere between 2 minutes and 30 minutes, can be up to an hour. And then the time from the onset of ingestion to death is around 30 minutes to 8 hours, depending on the person and their tolerances. It has to be drank all at once, so within the course of about 1 to 2 minutes, and it comes in a liquid. We pre-medicate people with Haldol, Zofran, or Reglan, or some combination, because obviously the worst case scenario would be that they drank the medication, got very, very nauseated, threw some of it up, but not all of it, and ended up sort of in a coma or with permanent injury, but didn't die. So we are sort of aggressively pre-medicate with anti-nausea medications. It's worth noting that no commercial insurance that I'm aware of would pay for this medication. So this is an out-of-pocket expense for patients. The DDMP2 formulation is between $500 to $600 out of pocket. Okay, there is some evidence that some other, I don't know of anyone who's used this in Colorado. I think that there are some practices in other states using a slightly different formulation called D-DMA. The dash is actually important because they separate out, I'm sorry, it's digoxin, not digitalis. Correct that on the slide. Digoxin, 30 minutes before the administration of the other medications. So digoxin, 30 minutes before, then diazepam and morphine in essentially the same doses, and then amitriptyline in space of propranolol. The suggestion here is that this particular formulation kind of shortens time from ingestion to death by about 60%. Obviously, there's sort of a lot of distress for family who is sort of at bedside when it comes to the time period between a patient falling asleep and then the onset of death. And there's sort of general interest in shortening that to the degree that it is safe, so that there's no undue suffering on the part of survivors. That said, the DDMA formulation, just so you know, is, like I said, this is based on unpublished data. So standard of care here at the University of Colorado, and I believe in Colorado in general, is still DDMP2. Okay. So say you get asked to participate, or you're asked to sort of fulfill one of the other roles. This is what you actually have to do. So if you're the attending, you're the primary prescriber, you must, one, determine that the patient is qualified. So they meet all of those criteria. They are a legal resident of Colorado. They're 18 years of age. They have the capacity to make this decision. They're not being unduly influenced. They have physically capable of making the decision. Physically capable of taking medication. That is, you have to determine that, and you have to document it. You have to collect their proof of residency. So it actually, if they're, their voting card, their voter registration cards, or their Colorado license, or a tax return, that has to be collected and documented. You have to do a full disclosure of risks, benefits, burdens, and alternatives, a full informed consent. You have to let the patient know that they may rescind at any time. So at no point in this process are they obligated to continue, including up to having the medication in hand at bedside. They can say no and just stop at any time. that you obviously have to write the prescription for both the medication and the supporting medication, and then you have to fill out the attending reporting form and sign the death certificate. So there's a form that goes to the state to sort of for some general demographic information, and then you sign the death certificate. I'll point this out in other slides, but so you know, and I'll reiterate this again later, when you sign the death certificate, by law, the cause of death is the terminal illness. It is not the ingestion of medication. That's actually very clearly explained out. So if you ever are in the position where you write this prescription and you have to sign the death certificate, cause of death is the terminal illness, if it's cancer or heart failure or whatever. Consulting physician, the only actually thing the consulting physician has to do is they have to meet the patient, examine them and their records, and they have to confirm in writing that the individual meets criteria. Essentially, the consulting physician is there as a backstop to make sure that the boxes are checked, that the patient meets criteria, that they meet the prognostic criteria, and that another physician confirms. And then if you refer to psych, the psychologist or psychiatrist's responsibility is to communicate in writing whether or not the individual has capacity. If they do not, then that person is not eligible to participate in receiving a prescription for medical aid in dying. Again, you don't have to refer to psych if you feel that there is no significant question of a patient's capacity. Okay. This is just a little bit of more granular detail. So Colorado resident is defined by law as someone who has a Colorado driver's license or a voter registration that's valid in Colorado, or owns or leases property in Colorado, or pays taxes in Colorado within the last fiscal year. So it's not like somebody can say, oh, I paid taxes in 2012, and it has to be, the last year's taxes. Any of those qualify as Colorado resident. From the attending physician criteria, this is interesting because it's actually written into the law and it's not particularly clear. So the attending physician or the primary prescriber is, quote, has primary responsibility for the care and treatment of a terminally ill individual. So who that actually is isn't defined to any more granular detail than that, right? And so, it stands to reason, okay, for a patient with cancer, that might be their oncologist. It could also be their primary care doctor. And the question is who sort of takes primary responsibility. We talk about this in palliative care a lot, which is this idea, does a palliative care physician ever really have primary responsibility for the care and treatment of a terminally ill individual? Maybe in some cases, yes, but in other cases, no. And then moreover, the question basically of if, say, I use oncology a lot as an example, but say you have a patient and you're an oncologist and you're administering chemotherapy and you don't want to participate in medical aid in dying, if that patient gets a different oncologist to prescribe a prescription for medical aid in dying, does that new oncologist then have to take over the chemotherapeutic plan? Because are they then the primary responsibility for the care and treatment of the terminally ill individual, or can they just sort of be an oncologist? These are things that are not perfectly prescribed within the law. I'm just kind of giving you a sense of what it actually says and what sort of the vagaries are. Self-administration is defined as affirmative, conscious, and physical act of administering the medication. Right? So both a sort of a cognitive and a physical, and sort of like a mental, emotional ability is all sort of baked into the idea of self-administer. And then again, a patient can rescind the request at any time. Right? And for what it's worth, and we'll talk about this in a second, if a patient rescinds the request, they don't need a measure of capacity when they do that. So you can imagine, so somebody says, yes, I really want this medication. Say they have dementia, right? As an example. I really want this medication. You think they have capacity in that moment, right? Or you determine they do. You can imagine that 3 months later, they might not. Right? You don't need to necessarily get a medical durable power of attorney override to say that person does not want the medication. If they say they don't, regardless of kind of what their mental state is, they can rescind. Okay. If you're following along, there's no voting mechanism here, but I thought I'd test you. So I want you to select what's not true. Okay. A person may rescind their request for medical aid in dying at any time. An institution may prohibit an employee from writing prescription that will be taken on their premises. Writing a prescription for MAID is legal in Colorado, but illegal nationally. And a person cannot self-administer the medication, may not participate in MAID. Okay. So which of these is not true? Okay. If you guess C, you are correct. Oh, look at that. Sorry, I'm getting chat notifications. Excellent. So the answer is C, right? So it is not illegal nationally. It is not legal nationally. There is no national definition of legality for medical aid in dying. It is up to the states, according to that Supreme Court case that I talked about earlier, to determine whether it is legal within the sort of borders of their state. Okay. That also begs a general question, and you really should counsel patients, if this is something that comes up, that they should not take this prescription out of state. And so they receive the prescription here. They shouldn't like go to Montana to take it. They have to take it here. Okay. Okay. All right. A little bit about kind of current state and a little bit of current controversy here in Colorado. So, and this was something I think somebody asked to include here. It's sort of worth knowing a little bit about. Okay, so Dr. Barbara Morris is a physician here, a primary care physician who's employed by Centura Health, or was formerly, who had a patient come to her and say that they were interested in pursuing medical aid in dying. I don't remember what their primary diagnosis was, but according to the bylaws of Centura Health, they sort of prohibited their staff from participating in writing prescription for medical aid in dying for a qualified individual. So Dr. Morris essentially, I believe, filed suit saying that the hospital restriction violated the state law. As a response to that suit, Centura Health terminated her employment. Okay, so the controversy here is a few things, and we'll get into it. And this is mostly to describe a little bit of kind of the legal state of affairs in Colorado, but also some of the ethical state of affairs for your consideration so that you sort of understand. The law is actually written and says a healthcare facility may prohibit a physician employed under their contract from writing a prescription for medical aid in dying for a qualified individual who intends to use the medical aid in dying medication on the facility's premises. That's the way the law is written. The emphasis is mine. Right? So there's this big gray area about whether or not an institution can prohibit a physician from writing the prescription if the intention is to take the prescription home and essentially do it on your own private property. For what it's worth, I don't know of anyone in Colorado so far, and this is not because I'm fully aware of the data, but I just haven't heard of anyone in Colorado who has taken a medical aid in dying prescription in a public hospital. I think almost every case has been at home or in a home-like environment. So I don't believe that excludes things like nursing homes or long-term care hospitals. But in kind of an acute care hospital, I don't believe that's been done. Although somebody can, by all means, correct me if I'm wrong. So this kind of question about to what degree an institution can prohibit their employees is sort of one that hasn't been perfectly worked out by the law, but it does specifically allow that only if the intention is to take the medication on the hospital's premises. The second part of this is that it's written into the law that a person may not be subject to civil, criminal liability or professional disciplinary action for acting in good faith under this article, meaning that I think that at the heart of this suit is the idea that certainly being fired constitutes professional disciplinary action for this physician who was acting in good faith. So that is the context of this current lawsuit. Sorry. Thank you. Okay. So a little bit of the nuance, just so you kind of understand the positions, can kind of come to your own conclusion, is I believe that I talked a little bit to one of the lawyers who's sort of involved in this case, but the supposition here is that Centura basically argues that the state law in Colorado conflicts with federal protections that are already in place that protect entities from participating in mandates that violate their religious principles. So Centura, I believe, is a Christian organization. It says that this law violates their religious principles. Right? And the precedent here is that Catholic hospitals sort of have the legal protection to prohibit prescriptive contraceptives specifically for family planning purposes in the context that they feel that it violates their religious principles. Dr. Morrison's case is that the law specifically provides protections against institutional reprisals for physician participation, and that no part of the law specifically allows institutions to prohibit employees from writing prescriptions that are then to be taken off premises. Okay, just for information. So that's sort of where it stands right now. We'll see in the coming months how this plays out. Okay, a couple more sort of legal, moral, ethical nuances to be aware of if you are put in the position to prescribe for a patient. Especially, like I said, about 20% of people in Colorado have primary neurologic conditions in the participation, and this comes up some. So this idea that should a person have a right to sign a contract where they say, I want this medication, and I meet criteria now, and I want it when it may be possible that I no longer meet capacity criteria later. Right? So you can think about something like dementia, right? Where somebody says, I know that when I get to a certain point, right, I want to take this medication, but I also know that that point may coincide with my inability to have capacity to do it in that moment. Right? And so there's this question of this thing we call a Ulysses contract, which is, from Ulysses, this idea that Ulysses asked his men to tie him to a mast, knowing that he would sort of be driven out of his mind by siren singing. It says, no matter what I do, don't untie me, right? I'm in sound mind now, but I won't be later. And there's this kind of question about whether or not that's possible. There's no real directive, right, about the determination of capacity over time in the law, right? So in the moment that somebody receives a prescription, they must have capacity. Right? But thereafter, right, there's no timeline that says you must take the medication and within this time frame. And so there's this question of what happens at home. Right? If a person has access to this medication, they don't necessarily have capacity in that moment. And this also brings up this problem, which we kind of call the 5 to midnight problem. It's sort of a colloquial term, but the idea is that there's the recognition that for some patients, not for all, right, but for some, they are sort of required by the way the law is written to take the medication before they're ready. And what I mean by that is most people, when they consider whether or not they would want to take a medication like this to end their lives peacefully, usually would want to do so in the context of their life no longer having meaning or value to them. And that's and that they, obviously that they are dying of a terminal illness, but that is very different by a different person's perspective. And a lot of people would say, listen, when I want this medication is right around the time that I'm no longer able to take it. Right? So this idea that I'm in bed, I'm so moribund, I'm so deconditioned, maybe I can't take the medication or swallow it, or I'm not awake enough, or I'm starting to sort of like lose my grip on reality. That's the time, right? I don't want to be bedbound, debilitated, dependent for weeks while somebody watches me die slowly. I want to be able to control the means of my own death in that moment. But that's exactly the moment where I can no longer take the medication. And I don't want to take it before that. And we call that the 5 to midnight problem, which is that there's this sort of consideration from a patient's perspective about when the right time is. And the way the law is written, sort of the recognition that you sort of have to preempt your own demise very slightly. This is sort of, these are just pictures of people who have brought this up, who have participated. Annie, I still can't pronounce her last name, but there's a documentary, if you're interested, called Before It's Too Late, about this exact problem. Audrey Parker is somebody who popularized this exact problem. Actually, she's a Canadian national. This is actually not legally national in Canada. I'm sorry, nationally legal in Canada from a kind of a federal perspective. But Audrey Parker was one of the people who recognized that she might have to end her life earlier than she wanted because of the way the law is written. Okay. Okay, question 2. All right, just to see if you're still awake. All right, so a person with end-stage lung cancer, continuously short of breath symptomatically, has an underlying opiate addiction and a history of bipolar, which is well treated, comes to your office to request a prescription for medical aid in dying. So which of the following is true? A, this person should not receive a prescription. B, this person's capacity must be assessed by a licensed medical health professional. C, you should ensure the patient qualifies under the law, ascertain the rationale behind the patient's decision, ensure their symptom burden is treated, and the patient is informed of the alternatives before proceeding. And then D, you should go ahead and write the prescription. Okay. We got a couple B's, a couple C's. Okay. Answer. I can advance the slide. Aha. C. So it's your duty to ensure that the patient qualifies under the law, understand why they want to do it, treat their symptom burden, and inform them of the alternatives. So this is the important part here. I won't get too deep into the bioethics of this, but if you're familiar at all with sort of the structure of medical bioethics, we say that really there are 4 pillars, although depending on who you ask, it changes slightly. But the 4 pillars are autonomy, non-malfeasance, beneficence, and justice. And that those 4 concepts should be balanced when it comes to bioethical considerations in medicine. So here at play is this concept of justice. So justice is the idea that marginalized or stigmatized populations should have the same access to standards of medical care available to others. And it's worth thinking about that line for this problem, right? So because somebody has bipolar or because they're alcoholic, right, does that mean they should not have access to this kind of medication? It would imply sort of a contrary to the idea of justice that they don't. So the question becomes, how can you make sure that you are acting within an ethical standard that is very, very high, but you are not impeding access to a subset of the population just for some sort of stigmatized condition? So the history of bipolar and drug addiction in this case doesn't necessarily mean the person doesn't have capacity, and that is something you can assess. Right? So you don't necessarily need a psychologist or a psychiatrist to determine capacity. Capacity is, broadly speaking, this is a broad definition, but broadly speaking, the ability to understand a medical decision put to them, understand the risk, benefit, burden, and alternative, make a decision based on their own personal values, and communicate that decision. And so you can imagine that somebody with bipolar that's well treated or alcoholism could very well do that in this case, but you should try to figure that out. At the same time, if there's any question, right, meaning if you kind of get through that and you say, listen, I just don't really know that this patient really understands what they're doing or they have the capacity, then you very much should. As a matter of fact, by law, you refer to a mental health counselor. Okay. And then obviously a prescription is never written at the first visit. There's a mandated 15 waiting period between a first and second visit. Okay. All right, just a couple last slides. One, data is not publicly reportable. So there's no specific list of providers or patients by identifiable health information that's kept, and that is to protect patients and providers. Cause of death on the death certificate, like we talked about before, is the underlying terminal illness not MAID. That's written clearly into the law. MAID does not affect life, health, accident insurance, annuity policies, any decedent rights or rewards. are not affected by the MAID process. And I believe, it's again written into the law, and I believe that there's an argument that it does. It's sort of, there's a protection within the law to say that basically that that's not allowed. That's something that I think comes up a number of times with patients when they're kind of concerned about how this will affect their property and their rights after death. And then the other thing that you should really be aware of is this is not something where you should refer to a hospice, meaning, I'm sorry, let me rephrase that. Medical directors of hospices, generally speaking, will not act as the attending or consulting physician for medical aid in dying. Kind of consider it a conflict of interest. So the point is, I don't want a patient to come to you and say, oh, well, let me just refer you to hospice and they'll take care of it. That's not really how it works. So again, the primary responsibility, the primary prescriber is the physician who is primarily responsible for the treatment of the terminally ill individual. And if that's you, you should remain in that role through the prescription of a medical aid in dying prescription. It is important, however, to counsel patients that they should, once they receive a prescription, it is highly beneficial that they enroll in hospice. The idea here is that when patients take the prescription, there is a latency between taking the prescription and actually dying. As we talked about before, it can be up to 8 to 12 hours, and that they won't be awake for that full period of time. But watching a person die, if you are a loved one who has never had proximity to what death looks like as it proceeds, can be a very distressing thing. And we like to make sure that our patients, at least here at the university, have the support of a hospice organization to help counsel family after the prescription is taken and help respond to any medical needs that arise once they're in a coma proceeding through their death. So we strongly advise that our patients enroll in hospice when they are planning to take this medication. But it's also worth noting that not all hospices will participate, meaning you have to let the hospice know that this is the intention of the patient, and they have to make a determination about whether or not they are comfortable taking that patient on. Some hospices will, others won't. It's a case-by-case determination, and you really need to ask. Okay, here are just some useful resources. So full text of the Colorado law is available under that website. There are two good references, sort of advocacy organizations that advocate for the expansion of end-of-life options that have lots of good kind of educational materials, both for patients and for providers, about how to do this in Colorado. Here are two of them. Counterpoint-wise, a well-considered and kind of appropriate guide to end-of-life decisions in opposition of medical aid in dying is written by the National Catholic Bioethics Center and worth a read as well. Okay. All right, so that is the conclusion. I tried to leave a little bit of time for questions, but yeah, thanks for listening. I hope this was educational for you.
Thank you, John. That was very, very informative and answered a lot of questions that I know I had, and I'm guessing that our participants had as well. So thank you for being so thorough. I do have a question that came across on the chat, and I encourage folks, if you have additional questions, to please use the group chat to post them. And if you see at the bottom, there is an option to post to everyone or to a particular person. So please post them to everyone so that Dr. Treem can see them as well. The first question that came through so far is, are pharmacies filling these prescriptions? Pharmacies have been a barrier in the past and not sure how they want to handle questions.
Yeah, oh, that's an excellent question. Thank you. So the short answer is that I know of no commercial pharmacies, so no like chain pharmacies like Walgreens or CVS that will fill this prescription. It is just like every institution. There's sort of an opt-out possibility for individual pharmacies. I know off the top of my head of 4 in the state that basically will fill the prescription. University of Colorado Pharmacy is one of them. But the long story short is no, you can't just send the prescription into any pharmacy. And it's basically, and the other part of this is that they actually need a compounding pharmacy. So the prescription doesn't come in like pre-made packet. It has to be individually compounded from the components and sort of mixed together. So choice of pharmacy is really, really important, and there are actually only a number that'll do it. So look up compounding pharmacies in your area and basically call and ask. That's probably the best way to do it. But I know that the University of Colorado Pharmacy here on the outpatient side does.
Okay, thank you. And sort of to piggyback on that, if a patient changes their mind about taking the prescription but has it filled, what happens next? What do they do with the medication? Do they take it back? Do they have to dispose it in a special way? What happens?
Yeah, another excellent question. So actually written into the text of the law itself, so you know, are two provisions for what to do with unused medications. One is to return it to prescriber. I'd say, okay, I don't want it here, have it back. And then the prescriber is obligated to essentially dispense within sort of the legal sort of pathways for a safe dispensation of dangerous substances, usually through a police department. The other is essentially the patient doing that themselves. So there are a number of kind of legal stations for drug take-back programs in Colorado, and essentially that prescription can be brought to any of them. It should not be dumped down the drain. It should not just be surrendered at a pharmacy. Most pharmacies don't have specific drug take-back programs. Most police stations do. But you can look up actually through Google sort of drug take-back locations and hours in Colorado, and you'll get a list of places.
Okay, very good. And you had mentioned that the MAID does not void life insurance. Someone had asked about that. And is there anything more to be said about that in terms of how communications occur with the family and the life insurance when this occurs?
Yeah, you know, for what it's worth, this is mostly an academic topic as of right now, meaning I don't know of any cases where this has actually become a conflict. The way again, this is just going by the law, the way the law is written is that, you know, the death certificate certainly gets sort of pushed to life insurance. And then under the sort of death certificate, the cause of death is the terminal illness. And there is a provision within the law that says specifically that prescription and ingestion of a prescription for medical aid in dying is not grounds for making any changes to sort of the dispensation of any post-life benefits. But exactly how or whether there are sort of loopholes within that, I don't believe has really been tested yet. So, you know, the truth of the matter is thematically, this is a relatively new law here in Colorado, and it's starting to sort of get a little bit more defined within the court system, as in the case of Dr. Morris. But there's still a lot of vagary. So we counsel patients that, you know, they are protected under the law from sort of alterations in dispensation of benefits after death, but to what degree that is sort of borne out in sort of a legal precedent way, we haven't really determined yet.
Okay, that's good to know. And the last question I have on the chat is, are there alternative options for those unable to self-administer, possibly a different state or anything? I know there are maybe a couple states that allow for a family member to administer, but what are the options in Colorado?
Yeah. So this varies by region. So euthanasia is universally illegal in the United States. So a physician or medical practitioner administering the medication themselves is illegal. I don't believe it's legal anywhere in the United States. I believe it's legal in Canada, actually, for what it's worth. In Colorado, at least, our law states that essentially no one can give you the medication. So, for example, we had a patient recently who couldn't swallow but did have a G-tube. Right? It's a liquid medication. It can be put through the G-tube. But the interpretation was that they had to take the medication in its mixed form and put it into their own G-tube. Someone couldn't do that for them. Um, Again, it hasn't really been challenged, but the supposition here is that essentially that definition of um, ability to self-administer is affirmative, conscious, and physical. Right? So if any of those are not true, like a patient needs to get medication from somebody else, like a family member, then that would probably be a violation of that statute, and we'd say they probably weren't eligible. That's sort of the way it is here so far, and unfortunately, we do counsel people a lot that sometimes means that people are just disqualified and they can't participate, even if they meet all other criteria. It's a little bit defensive that way. But we're just trying to make sure that we do this very strictly.
Okay. One quick question. There are two more that are on the chat, and perhaps you can see them, but I think we only have time for one more. Is if a patient's unable to find a physician that is agreeable to prescribe this medication, do you have a suggestion?
That is a really good question and a really hard one. So that's probably, at least in my opinion, the biggest barrier that exists in Colorado right now is how a patient finds a physician to participate if their primary physician is unwilling. Like I said, we don't keep lists, so there's no list of doctors who will see patients, and that's intentional. Right? That's to protect physicians from being sort of like having a practice around medical aid in dying, right? Or sort of being known in that way. So really, from our perspective, it's actually really challenging. We often, at least in the palliative care department, when we're trying to help a patient navigate this problem, go to the department that patient's in and say basically like, hey, listen, you have a patient, who's a part of your department, who's, the primary physician is this, very rightfully and sort of within their sort of legal rights, that physician has decided not to participate, right? But is there anyone in your department who will see them, to sort of keep it within a system and to try not to stigmatize it, right? To say it's not like, they're banished from care, and it's just that there's sort of anyone else within your physician work group who will. And then outside of that, there's sometimes some cold calling that's involved. I think it's hard because most physicians that I have spoken to are comfortable to a certain degree for patients that they know or they followed for a long time, or where they have like a good relationship with them, but very few of them are willing to see patients that they don't know specifically for the dispensation of medical aid in dying medication. That's a very different sort of personal, moral, ethical decision on a physician's part. So that's a long way of saying it's hard. I don't have a great way around it other than to sort of try to make a determination for yourself and talk openly to other physicians kind of about their own practices. And until there's sort of a kind of a better repository for information about participation in the state, it's tough. The only other thing I would say is both Compassion and Choices and some of the Death with Dignity organizations in Colorado may have better resources. So may be able to sort of do some of that primary sourcing for patients on their own. They have sort of patient advocates as opposed to sort of it being entirely on you.
Very good. Well, I know that is quite a barrier, and I appreciate your highlighting that further so that people understand they need to be informed as they continue to talk with their physicians when they're dealing with terminal illness to determine who they can see if they decide to exercise this.
Absolutely.
Well, we are over time. We certainly appreciate all of your expertise and your clarity around what this involves and where the limitations are. And we will have this recording available to those who were not able to attend or who may want to listen to it again. But one parting question, if people have additional questions that weren't addressed today, what's the best way to pose those? Can we relay them to you, or do you have another preference?
Absolutely. I'm happy to field Any questions, I can certainly help you get connected to resources to the best of my ability. Outside of that, like I said, some of the kind of local coalitions, like Compassionate Choices, may be able to help you as well. But you should feel free to send anything directly to me. I'm happy to help.
All right, very good. Thank you so much. I appreciate it. Thank you for
Pleasure.
joining
Thank
us,
you.
everyone. At this point, we will conclude this meeting. Thank you, John.
Take care.
Again, we really appreciate it. All right, bye now.